Thanks, Beth. Dr. Justin Goehl, the chiropractor, who works in the community and family medicine at Dartmouth Hitchcock Medical Center in New Hampshire, Lebanon, New Hampshire, which is in the, I didn't even look up where Lebanon is. But Justin, you can tell us later. He's part of the integrative clinic at the flagship ambulatory primary care facility for the Dartmouth Hitchcock Medical Center. He focuses on implementation of the primary spine care model in a pretty large health system that's really there to provide spine care to patients and streamline the process for any spine-related disorders. So at that location, there's an MD, a DO, a nurse practitioner, and a PA working together in different teams providing this primary care. The family medicine MD does do acupuncture, and another one who's training in functional medicine. So it's quite a broad spectrum of care they have. They work together for the same patient populations with Justin as a chiropractor managing the majority of the spine-related complaints, both from referrals and through direct access. I don't know how many of you know where that is, so just in terms of, I don't know where Lebanon is, that's sad, where specifically it's located. But it is the primary spine care center. I'm trying to glance through some other pieces of information I have here. Yeah, that's pretty the model they use. That they're trying to implement is Don Murphy's model of clinical reasoning in spine pain, or CRISP protocol. I hope that Dr. Goehl, you'll be able to explain more of that to us. So let me turn it over to you.
All righty, thank you, and thanks for having me. So first off, I guess Lebanon, New Hampshire is right on the New Hampshire-Vermont border, about halfway up the state. We're about 2 hours from Boston, about an hour and a half from Burlington, Vermont. So it kind of gives everyone an idea of where we are. So I thought first off I'd just kind of start off talking a little bit about myself. I'm a chiropractor. I graduated from Logan College of Chiropractic. I got my doctorate there as well as a master's in sports science and rehab. I'm a member of the second VA residency class, the chiropractic residency program, which is the only accredited chiropractic residency program. During my time there, I got to train in a really large healthcare system. I was located in Los Angeles, managing really complex cases and trying to navigate the electronic health records and kind of some things that, you know, maybe coming out of chiropractic school you wouldn't be used to or kind of be the standard. After completing my residency, I did an additional 6 months of training in the primary spine care model at Southern California University of Health Sciences. That really helped me to kind of take everything that I had learned at the VA and be able to implement those things through the primary spine care program and get that ready and get my skills honed so that I was ready to come to Dartmouth and work here. In addition, I'm certified primary spine practitioner, which is a new certification program. I was part of the initial cohort that went through the University of Pittsburgh's program. And in addition to my clinical work, I also hold academic appointment through the community and family medicine at Goehl School of Medicine at Dartmouth. So a couple of my learning objectives. I just want to give a brief overview of the primary spine care model for those of you that may not be familiar with it, and that'll kind of talk into some of the triage management and referral strategies for these types of patients. I'll talk about some of the key stakeholders that were involved in the implementation of my program and give a little insight into that. Some of the day-to-day things that we do as far as evaluation of me personally and then other providers in the clinic. Some challenges both financially and likewise that come up that maybe you guys can learn from, maybe some of my mistakes or things that haven't gone ideally, and then also talk a little bit about communication with other healthcare providers. So Dartmouth Hitchcock Medical Center, it's a 396 inpatient bed capacity hospital. It's a level 1 trauma center and also the only academic medical center in the state of New Hampshire. As you can see by the picture, It's a very large building, but it's surrounded by a ton of trees. So we pull from a wide range of patients. I think roughly 40% of our patients actually come from Vermont, with the other 60% coming from New Hampshire. But it's not uncommon for me to see a patient that is driving, hour, hour and a half, 2 hours sometimes for their appointment, because we have such a broad range that we're pulling patients from. We also have an affiliation with the VA in White River Junction, and obviously Geisel School of Medicine at Dartmouth. An interesting thing about Dartmouth is it's the first Center for Shared Decision Making started in Dartmouth in 1999. What that is a tool for patients and providers to utilize, where patients can get information about potential elective procedures and other health concerns, so then they can be involved in the process, hence the shared decision making, and be able to really be a participant in their health care, as opposed to things being kind of dictated to them. So they were kind of revolutionary in that sense, and it's still something that I think is very, very valuable. They're in the process of putting some components in our electronic health records for back pain that would be shared decision-making tools. I've become familiar with some of the other ones on things like mammograms and other procedures that clinicians can go through and talk through with a patient and really get to a point where the patient ultimately is making the decision based on having all the information presented in front of them. So in terms of integrated practice at Dartmouth, we don't have an official program. There's a couple of faculty members that are practicing in this model. The hope is to grow it to a program, but for right now, we're kind of practicing within the health system and kind of our models. The model that I'm in is primary spine care. That was kind of one of the first things to be able to show, okay, the sustainability and kind of learn. We have 2 primary care doctors that practice acupuncture, a family medicine doc and also internal medicine doc. So essentially all of our clinic is housed within primary care. And this is the building that I work at. So this is away from the main campus. We're maybe a mile down the road from the main campus, that houses family medicine, internal medicine, dermatology, PT, and also sleep medicine are all here. And patients really enjoy this facility because it's not the big monstrosity that was pictured previously. There's no parking garage. They park right, walk right in. It's very convenient, and patients really enjoy coming to this location. So with that, I'll kind of change gears here and kind of talk about spine care. So I kind of look at spine care. There's 2 sides of it. There's the clinical side of things, and then there's the administrative side of things. So on the clinical side, you have various pathways that you may utilize for patients to kind of get from point A to point B. Same thing with kind of care algorithms, based on, you're triaging patients and kind of moving them through the system in certain manners. Various members of teams that are working together, whether they're in a shared space or also in kind of different locations, and primary spine care kind of falls into that. And then on the administrative side of things, you have, I guess, the global landscape of spine care, which I'll kind of touch on here shortly. A lot of collaboration between departments and kind of figuring out the nuance of how to balance these competing entities in some instances, or they're complementary in other cases. And then obviously the various stakeholders that are involved behind the scenes with kind of keeping the place running, and then obviously the financial drivers, which in today's healthcare is a big thing. So a little bit about the state of spine care. The Bone and Joint Initiative found that in 2011 that 12 to 15% of physician visits per year are related to low back pain. If you add neck pain onto that percentage is only going to increase. And a lot of these are seen at the primary spine, or at the primary care level. So this is a large patient population that is coming in and seeing providers that, a lot of their training has been focused on managing chronic conditions, diabetes, heart disease, and things of that nature, and maybe not as much musculoskeletal focus. So, what they're looking at is this supermarket approach, where there's countless drugs, exercises, manual therapies, PT modalities, injections, surgical approaches. Various practitioners and ortho, neuro, PM&R, chiropractic, PT, acupuncture, massage, cognitive behavioral therapy, etc. The list goes on. And that's not even taking into account the variation amongst those providers. If you've been to one chiropractor, chances are you've been to one chiropractor. Everybody has their own technique, their own philosophy, their own method, and it's not that much different than a lot of the other professions. So it kind of puts the primary care provider at kind of in a corner where they aren't really sure, okay, how do I know which patient goes where? Which patient is a chiropractic patient? What patient is a PT? Which one needs to be sent to the orthopedic surgeon or the spine center? Kind of how's the best way to manage this? So enter primary spine care. So this is an approach to improve the spine care experience for the patient and kind of take some of the guess and check out of that. You're in charge of triage, management and referral, early conservative care, and have someone that can really be the point person for the duration of the spine-related disorder that the patient might be experiencing. If you look at a primary spine clinician, it's not a generalist. It's not someone who manages everything, even though you see primary, and I'm working in a primary care setting, my focus isn't on everything that's going on with the patient. If there's something that I can manage, that's something I'll be a part of, but if they need to be referred to another provider, then that would be done. This practitioner is designed to, or I shouldn't say designed, is focused on managing a specific system, the spine. The best analogy is a general dentist who provides primary care for oral health. Someone has something going on with their mouth or their teeth, more often than not they go to a dentist. You don't necessarily go straight to a orthodontist or an oral surgeon. You go to the dentist who then maybe makes that referral if it's appropriate, or they can manage those cases. This person has a less is more mentality, less procedures, less referrals, less imaging, really trying to centralize the care around this provider and utilize other providers as needed. So this person's designed to diagnose and manage the majority of patients with spine-related disorders using evidence-based methods. I always use the example, if there's 100 patients, a 100-patient sample, maybe 70 to 80% of those patients are going to be managed by this provider only. Maybe another 15 to 20 of them will be co-managed, whether that's with PT or primary care or behavioral therapist. And then maybe 2 to 3 of those cases might be surgical cases where the patient would be referred on to an orthopedic surgeon or a neurosurgeon to discuss different options going forward, potentially a referral to a pain clinic for an injection. And then maybe 1 to 2 of those patients have something going on that isn't necessarily spine related. Maybe it's related to the reason why they're presenting to the clinic that day, or maybe it's something that's just going to take a little bit more of a priority in their health as opposed to their back pain, where we kind of need to send things back to their primary or potentially make another referral. In addition, this person coordinates care. They coordinate referrals, they coordinate the follow-up, any testing, any invasive procedures that need to be referred out. They kind of manage throughout the course of this and are able to collaborate and communicate with the various providers, the primary, the PT, whoever else is involved in this care. They can kind of serve as the liaison for the patient to kind of coordinate the care. In terms of patients when they first come into our clinic, one of the screening tools we utilize is the Goehl Start Back screening tool. This is a 9-question questionnaire that's validated. It gives a little bit of insight about the patient's pain, how they're experiencing the pain, where they might be experiencing the pain. But then it also kind of gets into some psychosocial factors, anxiety, fear avoidance, catastrophizing, mood, worry, and kind of gives you basically your overall score, stratifies patients into low risk, moderate risk, or high risk for chronicity or maybe not responding well to care. From this, you kind of take that into account and maybe let that guide your care. So basically what research has shown that patients that are screened and treated with corresponding categories, which we'll get to in a minute, had better outcomes in terms of disability, quality of life measurements, and cost savings. So in terms of those categories, this is kind of the low risk, medium risk, high risk that I had mentioned before. So low risk, these are the people that maybe you're experiencing back pain for the first time. They're worried. They're kind of scared, but it isn't having a big impact on their life. These people do well. You give them some reassurance, maybe some self-management strategies, just some overall advice on things like things to do, things to avoid, and they tend to do pretty well. The medium risk, these people maybe have a little bit more of an impact on their activities of daily living. Maybe they're limited in their work capacity. You do the same thing that you do with the low risk, with the reassurance, self-management, but also maybe you add some exercises, some manual therapy. These are patients that you're probably going to have to put your hands on, and some of them may feel that you need to in order to do something for them, because that's kind of why they're in your clinic. And then obviously the advice that we talked about. And then the high risk, they check everything that the low risk and medium risk do as well. But these are people that may have some other challenges, whether they're suffering from depression or anxiety, or there's other components going on in their life that you may have to address these people a little bit differently, talk to them a little bit differently. That's where the psychologically informed therapy comes in. You may have to get a behavioral therapist involved with these people in order for them to truly kind of realize the best results, and just giving these people some reassurance probably isn't going to suffice. So that's a little bit of background information, I guess, kind of about the primary spine care model. Now I want to kind of talk to you a little bit about my position at DH. So I collaborate with a lot of different departments. As I said, I'm housed in family medicine. The building that I'm in has both family medicine and internal medicine, so I'm interacting with the primary care providers frequently. I'm included in all meetings and everything. So it's a lot about being seen and being in front of people, being present. That makes a big difference on kind of how many referrals you're getting, where people are thinking. I've noticed the people that I work with the most are the ones that are the closest to me in proximity in clinic, because they're seeing me on a regular basis. I'm also involved with the spine center. Obviously, if I have patients that are surgical cases, I'm sending them when appropriate to the spine center. I'm also working with the pain clinic. The spine center is, and likewise, they'll both send patients to me. They're very interested because they consider me kind of part of their team. I've been brought in for interviews for providers that are coming to join the spine center. They brought me in to be a part of the interview process, to interview the candidate and talk about my department, talk kind of philosophy and how they feel about chiropractic and kind of this primary spine care model. And then recently I was approached by a thoracic surgeon wanting to put together a thoracic outlet syndrome clinic, maybe like one day a month, like an afternoon, where it would be myself, physical therapist, thoracic surgeon, and anyone else who would be involved in kind of the care plan for that patient, kind of having a one-stop shop. So if someone presented to the clinic, we would schedule them out, and they would come in, and whatever kind of box that they fit in, they would be able to meet with that provider. That's still kind of something that's in the works, but that's kind of something exciting. The reason why I share this is the more you can kind of get your roots into different departments and in with different entities at the hospital, the more value you're providing, and the more people see the value that you provide to patients, and the more patients you're able to help. So it's helps with some sustainability as far as a position, but then it also allows your reach to grow with that. The other part that I think has really been a key component of the clinic setup that I'm in is the team room setup. So each provider more or less works out of 2 treatment rooms, myself included. Prior to that and then after the encounter, everyone comes back to a central team room. My team room consists of myself, 3 MDs, a DO, a PA, an APRN, a team nurse, and several medical assistants, all housed in one central room. This is where we do a lot of our documentation, where you do your prep for a case. in addition, there's a lot of communication and collaboration between providers, not just with me, but I get to hear other primary care doctors kind of converse about different cases and different management strategies, where it really does promote this team atmosphere. And I have an office. I probably haven't been in my office in a year because it's upstairs, and no one really on my team seems to go up there to do their documentation or kind of get away from the clinical setting. Everyone kind of stays there during the time. So that's I've kind of followed suit and done that. And I feel like that's been really, really imperative. And the people that I mentioned that I get the most referrals from are on my team, because I'm in the team room constantly being seen. They'll come over and talk to me and say, hey, is this someone I should send to you? Is this someone that needs to be going somewhere else? What do you think? Is this appropriate? So it's a real collaborative team environment. I also serve as a kind of a bridge to other departments. I'll have providers that maybe think maybe this patient should be going to the spine center. They'll send them to me and have me evaluate them first, just to make sure, hey, this is an appropriate referral. This isn't someone that maybe should be managed conservatively, knowing that then if the spine center gets the referral and it's kind of come through my clinic, it kind of adds a little bit more validity to the referral, and I think the spine center really appreciates the majority of the referrals that I've been sending there have gone on to have procedures and tend to be appropriate referrals, which that the idea is to have everyone practicing at the highest level of their license, and if an orthopedic surgeon is sitting down in front of a patient that isn't a surgical candidate, that's not necessarily the best utilization of their time. Another component that's beneficial for my position is it's a revenue generating position, in the sense that there is insurance coverage for the majority of chiropractic care for patients. So some of the barriers and hurdles that other people might face in other, I guess, positions where maybe there isn't insurance coverage, I kind of come in with that. Is it perfect? No, but there at least is kind of that known entity with that. So speaking of barriers, insurance coverage is still a barrier where we are, and both in New Hampshire and Vermont, there's no Medicaid coverage for chiropractic, and we still kind of live in a fee-for-service world. Fortunately, I haven't had a lot of demand placed upon me to see more and do more, because my focus is kind of the opposite, and really trying to provide a little more value and less procedures and things of that nature for patients. Another barrier is a knowledge gap, and this goes both ways. I think there's a lack of understanding from the allopathic providers of what I guess complementary providers do. I've had several people that I work with that when I tell them certain things that I see patients for, like, oh, I didn't even know you did that. But it goes the same way going back towards them. I feel like unless you're working with them every day, you don't realize some of the tools and procedures and things of that nature that they can do and manage, and the types of patients that they see. So there is this kind of divide as far as education of truly understanding what these various providers do, various specialists, the primary care providers. They do a lot of different things in the clinic that you wouldn't necessarily associate with primary care. So, the more we can do to bridge that knowledge gap and truly understand what they do and be able to teach them what we do, I think that's really key. There's also a credibility gap. Speaking kind of from a chiropractic perspective, and I guess a lot of other types of disciplines, there tends to be a less broad amount of research, less known about our training, as opposed to, most people at least understand, a medical doctor that goes to medical school, they do a residency, they may or may not do a fellowship depending on their focus, and then they're in practice. I feel like there's a little bit of a less known about our training, and maybe a little bit less experience with working with providers like that. Also, there's current pathways. The reality is I'm coming into a huge healthcare system that kind of has methods set in place as far as how back and neck pain patients navigate the system. And there's competing entities. The reality is there's so many people with back and neck pain that there's no shortage between myself, the pain clinic, the spine center. We're still all really booked. So it isn't really competing, but it's just that these pathways are kind of established, and it takes a little time to kind of turn those around and maybe kind of make some changes. As far as administrative buy-in, when me coming here, it was building a new department, a new service line. A lot of stuff goes on behind the scenes in order to make that happen. As far as getting, making sure equipment has been ordered, understanding what a chiropractor needs as far as with patients being roomed by an MA, my procedure's a little bit different than maybe a primary care provider, and having training in that and kind of the nuance of those things it's a big thing to take on. I was fortunate. The people that I was working with during that time were really excited because they'd never done something like this. People tend to get excited when they can do something new and challenging at their job. That was really, really important for me as a provider. Also, you have to get provider buy-in. You have to think of, sorry, I apologize, any previous negative experiences that someone might have had. There could be something that they think is a typical chiropractic experience that might be a little bit different. So what I've tried to do is give a lot of educational talks, speaking at spine grand rounds, speaking in internal medicine grand rounds, being able to educate people. The most recent talk I did was actually in my department, where I brought in one of our medical assistants and actually just treated her in front of some of the providers and just let them kind of see what I do and let them watch, and I kind of talked through the process, what I was trying to accomplish, and got a lot of really good feedback, a lot of questions, and then at the end I just kind of opened it up. I'm like, I'm an open book. Ask me anything you want chiropractic wise. And kind of got bombarded with questions in that regard, but it was really good. It was a really good experience. The important thing is that people see what you can offer their patients. The reality is a lot of these providers, they're willing to seek anybody out as long as they feel like it's beneficial for their patient. So that's really important. As far as administrative challenges, evaluations have been a challenge. Being the only chiropractor there, how do you have, if you don't have another chiropractor in the building, how do you do the evaluation? We had to find someone in the state of New Hampshire who was practicing in a somewhat similar environment that could review my notes or was familiar with Epic and could review my notes. Obviously, there's self-evaluation, there's peer evaluation between myself and some of the family medicine docs, as well as the support staff. One of the big questions I get as far as documentation, like I had mentioned, we use Epic. It isn't necessarily a chiropractic documentation platform, but the key is if you can have really good templates built, it can really make the system kind of seamless. I was fortunate that one of the techs through the EMR system told me about a SharePoint where essentially if you're a chiropractor practicing within Epic, your templates are shared on this website, and I could pick and choose various kind of things that I liked or liked the look of or like the phrasing that other people were using in my profession. And then obviously I reached out to some colleagues that are working in Epic and kind of picked their brain and maybe got some information from them as well. As far as classification, so I was brought in as an associate provider. We did that strictly for time purposes. It would have been a long, drawn-out process if I was brought in at the physician level. I'm now in the process, having been here for 2 years, being transitioned over to the physician level, which has some impact on benefits, retirement, salary, etc. The reality is there's not a ton of data if you're looking to negotiate this. There's not a ton of data out there where you can kind of say, okay, hey, this is kind of the standard of what you should expect. As far as scheduling, that's probably on a day-to-day basis on an administrative side of things. This is probably the thing that I deal with the most. making sure that patients can have direct access, or those that require referral, they are getting the referral. I built my schedule to where I have blocks so that, later on in the week I'll have same-day appointments, but, you can't have all same day. Otherwise, then if those don't fill, then you have empty time slots. So I found a pretty good balance where I allot 15 clinic slots for new consults, and then those new consults kind of feed the remaining follow-up appointments, and that balance has worked out pretty good. But it's a trial and error in that regard. You may have some individuals that you need. So there may be some weeks where you need more new patients than inevitably the next week you're going to need more follow-up because you're getting these new patients into the clinic and kind of getting it rolling. So I found a good balance with that, but it does take a little bit of trial and error. As far as feedback, it's been really, really positive. I feel like patients really enjoy the consistency of care. They appreciate that I have access to their health records. I can look back through a ton of data, and they don't have to tell me everything. I can kind of know those things, and they appreciate that. They appreciate that I work alongside and I'm in communication with their primary care provider or the referring provider, and they really love the location that I'm close, just down the hall. More often than not, I can walk down the hall and talk to a provider. These are just some of a few quotes that I just had from my my supervisor. The first one's kind of a little bit kind of talking about the shared decision making, where I kind of lay out my thoughts and what I think is going on with the patient, and then they kind of get to tell me what they're thinking and tell me their thoughts as opposed to dictating that. And it really empowers the patients to feel like they are in control, which is a very important thing when you're having back pain, because sometimes you don't necessarily feel like you're in control. So to kind of wrap up a little bit about my experience. So I think it's been really important to be at a teaching institution. They're very open to complementary options. They're very open to anything that will help the patient. Everything we're doing is evidence-based. There's a very good knowledge base, even for the musculoskeletal side of things, and everything. It's a lot of things. If they don't know the answer, they're going to find it. The benefit with the EMR is that I have access to imaging labs and procedures. I can go back 15 to 20 years and look at imaging. This reduces unnecessary testing, unnecessary imaging, and overall is going to drive down the cost. And in terms of communication, so I see on a day-to-day basis what primary care providers deal with in terms of communication, both from patients and other providers, and it is absolutely overwhelming. I think it's probably the thing that they are least satisfied with their job about. I say this so that if you are working with a primary care provider, if you're sending them your report, it's great to send your whole note. That's great. Just know more often than not they aren't going to look at that. I know that after every new consult, I send my note to the referring provider, and I know probably 99% of the time they don't look at that. So I tend to write just a little short blurb of, hey, these are the overall highlights. This is what I think is going on. Here's what I think is appropriate. And I'll keep you updated type of deal. And obviously having a team atmosphere, that's kind of where this picture comes in. So this is Halloween of this year. It's myself, a chiropractor, one of the MDs on our team, which is new, a PA, an RN, and an MA, all within our team room that are kind of shows this collaborative team environment where everyone just kind of works together, and it really is a fun place to work. Obviously, maybe we had a little too much fun that day, but overall, it's a really good team environment that I've really enjoyed. So hopefully this gives you guys some information about my experience. You can maybe take some tidbits from what I've learned through my experience and can bring it to your own practice. And with that, I just want to say thank you. This is my email. Feel free to reach out to me. And at this point, we can open it up for questions, and if anybody has anything.
Thanks so much, Dr. Goehl. So, yeah, actually, I have a couple questions, but I'd like to hear. I don't want to cut other people off. So, questions?
Well, Marcia, you can go ahead and start, and I will go through the process of unmuting everybody. If you want to put something in the chat box,
Sure.
that's great, but otherwise I'll unmute you. And again, keep yourself muted if possible, just to help out, but I'll go through and unmute everybody. So thanks, Marcia.
So I guess my first question is, what advice do you have for us working with students in terms of collaborating and establishing the relationship with either a welcoming other provider or one who is skeptical or a little removed? What do you think are some key things that you could share that you learned?
I feel like it's really important, if possible, to get face-to-face time. You know, it's really easy when you're reaching out to someone electronically over the phone for them to say no, or say no thank you, or no, I'm not really interested. But when someone's right in front of you, they might give you a little bit more of a chance to kind of get your foot in the door. But whatever you can do to reach out, to try to set up a time to where you can just go and maybe explain what it is that you do and how you could potentially help their patient population. Or maybe in my scenario, what I look at my position, I'm kind of taking some of the musculoskeletal cases and taking that burden off the primary care providers and allowing them to kind of manage some of the more complex, you know, diabetes, heart disease, some of these chronic conditions that they're really well trained to do. If you could take away some of the patients that maybe they don't want to see or they don't like to see because they feel like they can't really adequately manage it. If you can unburden them and then show that you can help their patients, they're going to be a lot more responsive to that than make it more about them and their patients and less about you, I would say.
That's fantastic. People always want to hear from someone who can take some of the burden off of them. So thanks for that. Do I have other questions?
We have a question in the if you can put your question in the chat, it's a little bit easier to read, but we do have a question in the question panel, so I will do my best to read it, and then we can ask people to either put in the chat or to raise their hands, or we'll figure it out.
Okay.
But it says, regarding your immersion into a mainstream environment with charting and coding and the initial challenges therein, because this wasn't an aspect you were trained in chiropractic school, what is your opinion of the importance of chiropractors being taught some of these aspects of mainstream conventional settings so there can be easier integration of teams? And what else do you consider important for integrative providers like massage therapy, acupuncturists, chiropractics, etc., to know or be taught to adjust to the mainstream working environment and culture?
Yeah, so it was kind of baptism by fire, and starting at the VA. Working in a huge healthcare system like that was very challenging. It is, you know, some of the things we are taught really well in chiropractic school. But there are things as far as, you know, some of the coding. A lot of times if you're looking at big institutions like where I'm at, they have someone who's in charge of coding. I know that my first 10 charts that I completed didn't go out until I met with the coder and we went through and made sure that I was billing appropriately. So depending on what type of system you're looking at, there's a lot of resources available that you could utilize. But I think the more you can learn about, as I talked about, the other providers and what they have to offer, and truly have an understanding of kind of some of the nuance of a big healthcare system and how kind of patients navigate their way through, which is easier said than done. But the more you can really learn about that process and kind of the standard of care, which is going to be different everywhere you go. You know, some patients, depending on where you are, anybody with back pain may go to a spine center or something like that, as opposed to, you know, a lot of times they're coming where I am to a primary care provider. So, you know, depending on which type of health entity you're looking to work at, kind of understand the nuance of how patients find their way through the system. I hope that answers the question.
Well, thank you. And John Weeks has a question.
Yes.
Let's see, John, are you unmuted? Let's see, John. Yep, John. There we go. I'm trying to unmute you, John. It says you're self-muted now, so try to unmute yourself and see if that works. And it still says you're muted by an organizer. Okay. John, I'm trying to unmute you, and it's not allowing me, so we'll come back to John.
There we go.
Oh, there. Okay. All right. Good. All right, John.
That was an interesting dance. Thank you. Fascinating presentation. Thank you very much. I have two questions. One actually goes back to the preparation. You referenced the Pittsburgh program, the specialized program. I wondered if you would describe more about sort of what that entails and how important that was. And then second is just whether you've got outcomes from what's changed with you being there.
Okay. So in terms of the Pittsburgh program, thanks for the questions. So it's a certification that's offered through the University of Pittsburgh. It's a five-section course as currently constructed, which would require it's primarily built right now for chiropractors and physical therapists, at least the initial cohort. That was predominant makeup of the class. It's a five weekend course where you're going in and learning a little bit more about Don Murphy's model, and then also some of the University of Pittsburgh protocols that they utilize there, and kind of really immersing yourself in this primary spine care model and understanding, one weekend's devoted to low back, another weekend's devoted to neck, and another weekend's devoted to some of the psychosocial aspects of it. So you're kind of taking all of these different pieces and spending a lot of time. There's a lot of coursework done online beforehand, so that when you come to the weekend course, you can really hit the ground running, because the reality is people are coming from all over the country to do this. So you want to make sure you're getting the most bang for your buck during that time. So everyone comes in with a baseline knowledge, in addition to the manuals that Don Murphy has written, that everyone would be familiar with and you're kind of working with. As far as the outcomes, that's definitely something that
Could I do a quick follow-up, which is, it's 5 weekends on site plus online. Is there a price tag for this, or total number of hours?
I don't know. I don't know off the top of my head a price tag of total hours. I know that I'm trying to remember what some of the modules. I want to say, it was 20 to maybe 40 hours of coursework beforehand, and then the weekend course for each module.
And I know this is hard to do, but as you think about the input of your VA experience and then this other program, say how much each was critical to preparing you.
I would say they're both equally. So the VA really prepared me for working in this big healthcare system and understanding how to navigate the health records and the other providers. It was really valuable in that regards, and managing really complex cases. And then the primary spine care model, having additional training in that was key in order for me to hit the ground running and be able to implement this at DHMC. I think if trying to do the primary spine care model at the VA isn't possible, just because of some of the barriers and things of that nature that people, that just kind of, it's a different system, we'll put it that way. They wouldn't necessarily be flexible and allow that. So there really are kind of these two separate trainings that kind of have merged into one at my position here, and I would say they're both. I know that the primary spine care stuff would not have happened if it was not for the VA. I will say that the VA was kind of the catalyst that really kind of started this cascade of events that with me at DH. Without that, I don't think you could. You probably could if you were really well versed in the primary spine care model, jump into a huge system like this, but the learning curve might be a little bit steeper depending on what type of model you're coming from.
Fascinating. Thanks.
And then as far as the outcomes, that's definitely, everything that I'm doing here, we are researching, we are collecting the data. I get probably 2 or 3 emails a week from Jim Whedon and other individuals as we're working through to collect this data and be able to show some outcomes and see, what type of results does this present for patients that are presenting to the clinic. So it's in the works, we'll put it that way.
Very good. Very interesting. Thanks much.
Yeah, no problem. Thank you.
Thanks, Justin. We have a question from Jennifer Johnson. You mentioned that it's easy to walk down the hall to chat with other providers with regard to patient care. Do you have standing meetings to coordinate with other providers regarding patient care, to model or share with students regarding integrative care? And she also asked, what is the site where you access the EPIC templates?
Yeah, I was just thinking that I don't have the.
I can email you that for Justin and then share it with the group afterwards.
If I can find that, I honestly haven't used it since I first got here because that was.
Okay.
So I'll locate the site and definitely give that to you. As far as, I don't necessarily have standing time with providers. It's more kind of on a case-by-case basis. We have standing meetings where we'll all be there, and afterwards, inevitably there's maybe a little bit of downtime either before or after where I can pop over and talk to someone about a case. But if it's something that I really feel like I need face-to-face time, I'll go find the provider somewhere in the building. And it's hard to juggle. They're in with patients, I'm in with patients. The reality is when you're in clinic, you're in clinic. You aren't really necessarily available. So finding time, that I'll leave a message saying, hey, you can pull me out of my next encounter. We can chat for a minute. And a lot of times that happens the other way. If they're in with the patient, we'll say, hey, next time, just pull me out of that encounter and come and talk. So that's it's kind of on a case-by-case basis, but there aren't necessarily standing times to discuss cases.
Thank you, Justin. And that's all I see in the question log, and I don't see anything in the chat log. If anybody else has something that they'd like to ask, please speak up now. We have 3 more minutes.
I have a question. This is Jim Whedon.
Hi, Jim.
Hi. So Justin, I'm interested in the shared decision-making piece. I'm wondering if you had any kind of training and implementing that in your practice, as a formal process, because it seems like, of course, spine care is a really good, appropriate place to be using shared decision-making, and now particularly because we have guidelines that kind of give equal weight to a variety of integrative healthcare interventions, where you might, very appropriately use shared decision-making with your patients. So can you talk a little bit about what that's been like for you?
Yeah. So no real formal training. It's kind of training on the fly, I guess, and kind of learning as I go. We just recently had a new provider join our team, and he's a Dartmouth grad, and he's really into shared decision-making. He's working on building some shared decision-making tools. He just gave a presentation about that. So when I look at his notes, he clearly, in his documentation for a plan, will list out 10 or 15 different options for a patient in the chart. He'll discuss those with them, and ultimately the patient decides, okay, would you rather, for this, here's kind of your options. You can go to a PT, you can go to a chiropractor, you can go to an acupuncturist, you can go to a massage therapist, you can go to any number of providers. Here's kind of my thoughts. What sounds most appealing to you? And then the patient kind of makes the decision from there. They have actual tools that he was going through in our most recent meeting. It was related to whether to do a mammogram once a year or every 2 years. And basically, they put in all the information from the patient, their history, if there's any family history that needs to be considered. And they look at side-by-side graph, or basically like for lack of a better term, 2 pictures that have little people on them, and it's 1,000 people. And basically it shows how many people, if they do it every year in this patient's demographic, how many of those people are caught as having this issue, how many people are wrongly diagnosed, how many people are over-tested, how many people die. And then they flip it to the 2-year and then look at that same patient population and see the difference. And they can go toggle back and forth between those and show the patient. So then the patient ultimately says, okay, maybe 1 less person dies if we do it every year as opposed to 2 years, but look at all these people that are, put through the system for additional testing or wrongfully diagnosed, and they can kind of weigh those options and weigh the risk, whether it's something they want to be in the part where, hey, we might get a false positive, or we may catch something that's really serious. They can prioritize that. So they're really cool tools. He told me they're working on something for back pain and neck pain, so I'm really excited that can happen, because during that presentation, I mean, a lot of the primary care providers are really, really excited based on what they were seeing.
They're working on that tool for back pain and neck pain. It would be great if the kind of decision making around the various integrative approaches can be worked into that.
Yeah.
Tool.
Yeah.
Well, we are at the hour. I want to thank everybody for participating and being on the call. And Marcia, thank you for moderating and introducing Justin. And Justin, thank you so much for this really excellent presentation and all your preparation and for answering all of our questions. This has been wonderful. And I think I'll sign off now, and Marcia, I'll let you say the final goodbyes to everybody.
Thanks, everybody, for joining in. This was a great presentation from my perspective, and it's very interesting because all of the questions that were asked by other people I had written down in my own list of things to ask. So thank you for filling in and getting my questions answered as well. Thank you so much, Justin, and everybody for joining us. Hope you have a pleasant, for all of you Americans, a pleasant Thanksgiving next week.
Thank you, everybody. We'll have the recording posted in the next week or two.
Great. Thanks. Bye-bye.
Bye-bye.
Thank you. Bye.
Thanks so much.